Hey everyone, and welcome to The Explainer. I am absolutely thrilled you're here today because we're diving into a topic that honestly leaves a lot of medical students and clinicians pulling their hair out. We're talking about ascites. It's so easy to just drown in those endless lists of causes you're supposed to memorize, right? But what if we actually approached it a little differently? Today, we're going to build a really logical first principles framework together. By the time we wrap up this explainer, the goal isn't just to memorize what causes ascites. We want to truly, fundamentally understand exactly why it happens, how to logically diagnose it, and of course, how to effectively treat it. So, here's our game plan for today. We'll start with the physiology of ascites, move on to decoding the SAAG, and then cover the nephrotic syndrome exception. After that, we'll hit stepwise medical management, dig into paracentesis, albumin, and SBP, and finally wrap up with tips and our final clinical approach. All right, let's jump right into part one. The physiology of ascites, going back to first principles. Now, before we can even think about treating a problem, we absolutely have to understand the baseline physiology, right? So let's get a clear definition on the table. Ascites is simply the abnormal accumulation of fluid within the peritoneal cavity. Now, in a normal, healthy person, your peritoneal cavity isn't totally bone dry. There's this very thin layer of lubricating fluid between the visceral and parietal peritoneum, and any excess, well, it's constantly being swept away by your lymphatic drainage system. So the crucial takeaway here is this. Ascites only develops when fluid enters that cavity faster than the lymphatics can clear it out. It's basically a classic supply and demand problem. So, zooming into the microscopic level, this delicate fluid balance is maintained by Starling forces acting directly on your capillaries. I really want you to anchor these two basic rules in your mind. First up, we've got hydrostatic pressure. Just think of this as the blood pressure literally inside the capillary. Pressure pushes fluid out of the circulation. Second, we have oncotic pressure. Now, this is primarily driven by albumin, which is a big, bulky protein floating around in your blood. Albumin attracts water back into the circulation. So remember this, pressure pushes and albumin pulls. When those two forces are perfectly balanced, the fluid stays exactly where it belongs. But when those Starling forces get disrupted, it leads directly to three, and really only three, physiological mechanisms that actually cause ascites. When the forces get thrown off, one of three things is going to happen. Number one, increased hydrostatic pressure. The pressure inside the vessel gets way too high, literally forcing the water out. We see this in conditions like cirrhosis or heart failure. Number two, decreased oncotic pressure. This means you just don't have enough albumin in your blood to pull and hold on to that water, so it leaks out, which happens in things like severe malnutrition. And then number three, increased capillary permeability. This is where inflammation or malignancy causes those capillary walls to get all damaged and leaky, letting both water and proteins just spill right out. It's pretty amazing, but nearly every single cause of ascites fits neatly into one of these three boxes.
Moving on to part two, decoding the SAAG, the ultimate solution.
Okay, so now that we've got the theoretical problem down, how do we actually solve this in a living, breathing patient? Well, we use what I think is one of the most elegant tools in all of medicine. It's called the SAAG, which stands for the Serum Ascites Albumin Gradient. To figure this out, you simply take a blood sample and a sample of the ascitic fluid on the exact same day. Then you subtract the ascitic fluid albumin from the serum albumin. It's just simple math. But the magic number here, the absolute critical clinical threshold you've got to commit to memory, is 11 grams per liter. So what does that number tell us? Well, a high SAAG, meaning a difference that's greater than 11 grams per liter, tells us the capillary wall is actually perfectly intact, the albumin is safely trapped in the bloodstream, but water is being violently forced out by high pressure. So high SAAG basically equals portal hypertension. It's a pressure problem. On the flip side, a low SAAG, so less than 11 grams per liter, tells us the gradient is small. Why? Because albumin is actively leaking out of the capillaries and into the belly right along with the water. The capillary wall is damaged. So a low SAAG usually points straight to peritoneal disease, like inflammation or malignancy. Fundamentally, it's a permeability problem. Let's look at part three, the nephrotic syndrome exception. Now, as with all great medical rules, there is a major plot twist. We have to talk about the one massive exception to the low SAAG rule, and that's nephrotic syndrome. In nephrotic syndrome, patients are dealing with massive urinary protein loss. I mean, they are literally peeing out their albumin. Because of that, their baseline serum albumin drops dangerously low. So, when you go to do your SAAG calculation, the mathematical difference between the serum and the ascites is incredibly small, well under 11. That gives you a low SAAG. But here is the kicker, and you can't forget this. There's actually no peritoneal inflammation happening here. The capillary wall is totally 100% intact. The SAAG is low purely because of a math problem created by profound systemic hypoalbuminemia. It's a tricky one, so we always have to keep this exception in the back of our minds. All right, part 4, stepwise medical management. Okay, so we know exactly how the fluid gets there, and we figured out how to diagnose the cause. Now the million-dollar question: how do we get rid of it? Let's walk through stepwise medical management. We really want to approach this logically, escalating our therapies step by step. Step 1 is super conservative, dietary sodium restriction. We just want to stop the body from holding on to more water. Step 2 is where we bring in medical therapy, specifically spironolactone, which is our frontline diuretic for this. If that's not enough, we go to step 3 and add a loop diuretic, like furosemide. Now, if the fluid still stubbornly won't budge, we have to escalate to invasive procedures. Step 4 is a large volume paracentesis to literally go in and physically drain the fluid. And finally, step 5, for those really refractory stubborn cases, is a TIPS procedure. I actually want to pause on step 2 for just a second. Why spironolactone? Why is this our very specific, precise molecular counterattack? Well, it's because cirrhotic ascites is primarily an aldosterone-driven disorder. The diseased liver triggers this massive cascade that basically makes the kidneys panic. They respond by releasing huge amounts of aldosterone, which aggressively hoards sodium and water in the body. Spironolactone is brilliant because it directly blocks that aldosterone receptor in the kidney. You aren't just handing out a random water pill here. You are directly chemically neutralizing the exact physiological mechanism that's causing the fluid retention in the first place. Moving on to part 5, paracentesis, albumin, and SBP. So what happens when the medications just aren't cutting it, and the patient is sitting there deeply, deeply uncomfortable? That's when we turn to interventions that provide really rapid relief. But we have to be incredibly careful here because they come with significant physiological risks. When a patient's abdomen is tense and super distended, we perform a large volume paracentesis. We insert a catheter and physically drain that fluid. And honestly, it feels amazing for the patient. But here is the absolute critical threshold you have to remember: 5 liters. If you pull off more than 5 liters of acidic fluid, you absolutely must give that patient intravenous albumin replacement. Let's break down why that is. If you suddenly drain massive amounts of fluid, the physical pressure inside the abdomen just drops off a cliff. When that happens, the blood vessels in the gut, the splanchnic vessels, suddenly dilate wide open. Blood pools in the gut, which means way less blood is actually returning to the heart. Suddenly, your effective circulating volume plummets. The kidneys sense this drop and perceive it as severe dehydration, so they clamp down aggressively in a total panic. This cascade is called paracentesis-induced circulatory dysfunction, or PICT, and it is bad news. It can rapidly lead to fatal hepatorenal syndrome. So we give IV albumin because its oncotic pull draws water right back into the blood vessels, holding up that circulating volume and keeping the kidneys perfectly happy and perfused. And while we're on the topic of the fluid itself, we've got to talk about infection risk. Acidic fluid in a patient with cirrhosis is extremely protein poor. We're talking usually less than 15 grams per liter of protein. Why does that matter? Because crucial immune proteins, things like complement and immunoglobulins, are missing. The fluid is basically a defenseless swimming pool. Bacteria from the intestines can easily cross right over into it and just multiply like crazy. This leads to a really dangerous condition called spontaneous bacterial peritonitis, or SBP. And that's exactly why these specific, high-risk patients require prophylactic antibiotics just to survive. Finally, part 6, tips and final clinical approach. So let's say we've tried the diet, we've maxed out the diuretics, and we've done the paracentesis. What if the fluid just keeps stubbornly coming back? Eventually, we have to bypass the problem mechanically. And this brings us to TIPS, the transjugular intrahepatic portosystemic shunt. It's essentially a stent that gets placed directly through the liver tissue, physically connecting the high-pressure portal vein straight into the low-pressure hepatic vein. The benefit? It's like a magical pressure release valve. Portal pressure drops instantly and the ascites often completely resolves. But we really have to look at the risks here. By doing this, you are shunting blood completely around the liver's natural processing centers. Toxins like ammonia, which the liver would normally filter out, now completely bypass that detoxification process and head straight up to the brain. This drastically increases the patient's risk of hepatic encephalopathy. So TIPS fixes the hemodynamics beautifully, but it deeply, deeply alters the body's systemic metabolism. So, bringing this whole explainer together, our entire clinical approach really boils down to this one core philosophy. Think physiology first. Identify the actual mechanism of the ascites by looking at the Starling forces. Interpret the SAAG to figure out if you're dealing with a pressure problem or a permeability problem. Treat the underlying cause, and then logically escalate your management from sodium restriction up to targeted diuretics to paracentesis with albumin, and finally, if needed, TIPS. When you truly understand the why, I promise you'll never have to blindly memorize the what ever again. Which leaves me with a final thought for you to ponder today. We just took one of the most notoriously complex, headache-inducing topics in gastroenterology and completely demystified it using just a few basic rules of pressure and proteins. If every single cause of ascites can be decoded through these basic physiological rules, what other complex medical mysteries do you think we can solve simply by returning to first principles? Think about it. I really hope you enjoyed this explainer as much as I enjoyed guiding you through it. Until next time, keep questioning and keep learning.